Welcome everybody to GoLocal Live. I'm Josh Fenton, CEO and co-founder. I want to thank a couple of guests from this morning. John Wolf from the San Miguel School in Providence, a very interesting peek into how they're handling distant learning. Secondly, I want to thank David Sirota from the formerly of the Bernie Sanders campaign. He was a speechwriter and kind of message guy, very, very smart political thinker, and now is the author of TMI, the newsletter, Too Much Information. If you haven't signed up for it, take a look at it. It gives huge views into the world of politics today in the United States. We're going to go to Dr. Michael Fine in 1 second. I do have a programming correction that I made earlier today. Governor Raimondo's briefing is at 2:30 today, not at 1 p.m. I apologize for that mistake. Again, she will not allow reporters' phone calls during those live that people can hear during those interviews. Let's go to Dr. Michael Fine. Dr. Michael Fine, thanks so much for joining us today.
Good afternoon. It's nice to be here.
Let's go to it. Lots of information flying. Let's go right to the numbers, and then we can jump off from there.
Sure. 700,000 people have recovered around the world. There are now 2.58 million cases, shortly to be 2.6 by tomorrow. The rate of growth is about stable. In the U.S., we're at 820,000 cases. Also, we're seeing about 25,000 to 30,000 new cases every single day. 179,000 deaths around the world, climbing at a pretty stable rate of 6,000 to 8,000 deaths a day. In the United States, we're at 45,000 deaths, climbing at a rate of 1,100 to 2,800 deaths a day. No radical change in that regard. In Rhode Island, we're at 5,500 deaths, 5,500 cases. Yeah. And that's up almost 400 in the last day. 16 new deaths, 171 deaths in total, always tragic. 271 people in the hospital, creeping up, but creeping very slowly, thank goodness. And 67 people in the intensive care unit, 43 people on ventilators. The growth in hospitals and ICUs has been amazing. We have been very, very stable. Progressive growth for sure, but not huge growth. And that's something that we're still in the level of hospitalizations and ICU use that we have capacity for. Thank goodness.
Number of cases per 1 million, Rhode Island is 6th in the nation. Number of cases per 1 million number of deaths per 1 million, Rhode Island is number 8 in the country. How do you measure? How are we lucky enough to keep those ICU numbers down, because we are capped at a significantly low number, and balance those cases and those death numbers?
It's a answer that I regret to give, but part of that is by our deaths. Yeah. People are dying out of the ICU, and that provides new openings. That's my guess.
At the nursing homes, yeah.
Yeah. And the other good news is, because we've been very effective at social distancing, as I see it, our rate of growth is way slower than we anticipated. And that will give us time to build the capacity we need. And it looks like we may have the capacity we need. We'll see. But remember, the flip side of that slow growth is a very long plateau and a fairly substantial time in suspended animation. The good news about social distancing is that it keeps that peak from being undoable. The bad news is it's a good way to stop the spread of the disease, but doesn't actually point to a departure from social distancing, which is what I think we all so desperately want.
Listen, a lot of news in the last 24 hours about our healthcare system fraying, and let me give you some of the numbers. First, in March, Lifespan has announced that they've lost more than $70 million. in that single month. Secondly, Butler Hospital's nurses, through their union, sent out that they have 10 cases between patients at Butler and staff, and that there is virtually no PPE available there. Charlesgate Nursing Home, the union there makes the same argument. Very little PPE available to those frontline workers. While good news on the front of keeping a suppressed number from the ICU and from overall hospitalization, a lot of questionable issues now emerging about the health of our healthcare system. Your thoughts?
Well, I'll say again what I've said before. We do not have a healthcare system in the United States. We don't have a system in Rhode Island. We have a market, and the market is there to maximize profit. So when we run into one of these actual public health emergencies, we just don't have a coherent approach to dealing with it. The good news is that everybody stepped to the plate and is working hard to keep hospitals supplied as best as they can with PPE. We're not in terrible shape, though certainly it sounds like there are some real spot issues for sure. But on the financial survivability side, what I'm hearing is that 20% of all primary care practices are likely to go out of business in the next couple of weeks. We are going to see tremendous disruption because we built a market and not a system. And I only hope that we use this opportunity to understand we are one system, that we ought to be providing one set of services to all Rhode Islanders and all Americans. This is something we have the financial capacity to do. The question is whether we have the political fortitude to do it.
Some good news. Brown University stepped forward yesterday and has dedicated an entire quad, 700 rooms, for frontline healthcare workers to be able to use so they don't have to go home after their service each day and infect their families. That's great news. And give credit where credit is due. Sometimes there's the town gown stress between the colleges and universities and the rest of the community. This was an outstanding step up by Brown. Your thoughts on that type of collaboration?
Well, I think that's the kind of collaboration we need. For me, and I've said this before, the next step, it's great to have that for healthcare workers, but we also desperately need out-of-home isolation for people who live in densely packed living environments. And I am really hoping that our colleges and universities can help us get to that and get to it really quickly. Because for me, the way to back out of this, the way to open up again, is really a much more locally focused approach than we've used. I think every locality needs temperature screening. I think we're going to have to keep with masking until there have been no cases for weeks. I think we're going to need immediate out-of-home isolation the moment someone is symptomatic, if they live in a crowded living environment. I think we need immediate access to testing, and then if we're going to do contact tracing, we got to start it right away, not wait or not have to wait because of built-in delays for 2, 3, or 4 weeks.
Doctor, talk a little bit about the issue of testing, your thoughts. You've sort of, as you've learned more, had some greater development of thinking relative to those who are coming out of isolation and the need for them to be tested.
Sure. Well, I think I was wrong about testing people coming out of isolation when I first proposed it. And I think what we've learned is that the false negatives for testing people who are asymptomatic are really too great for it to be useful. We still need what I'll call a gold standard test, a test that will help us detect disease in people who are asymptomatic. So testing asymptomatic people, I'm not convinced, is going to get us anyplace. There was an interesting piece in yesterday's New York Times which showed the per capita testing available in Rhode Island is better than anybody else in the country. which is fantastic. But I don't think testing alone is going to get us there. I mean, I think the challenge is testing, yes, but testing, the most important thing to me is immediate isolation, so we stop disease spread. Immediate isolation, some of those other things I talked about before, combined with testing, absolutely. But testing alone, it's just not going to get us where we need to go.
Dr. Fine, the head of the CDC, Robert Redfield, came out with, very significant and sobering message for America yesterday, saying, listen, this coming winter is going to be brutal, the worst period of time. The overlapping flu coupled with the coronavirus are likely to potentially overwhelm our healthcare system. We need to build up everything during this period of time. I'm not sure most Americans were ready for that information. Your thoughts on Mr. Redfield's comments?
Well, the first thing that we ought to do as we build up that capacity is make sure all Americans get immunized against influenza. Look, influenza vaccination isn't perfect, but it's the best thing we have. And most people don't know that we, on average, vaccinate only 37% of Americans. If we could vaccinate 80 or 90%, and this is the year to get it done, then there's a chance of us achieving herd immunity for influenza. So that would take that monkey off our back. And the other interesting thing to me is to see how social distancing affects the transmission of influenza. Because technically, if we stay with social distancing, that may help turn down the influenza part of what's coming at us.
When will this winter's a flu shot be ready?
Usually by October, sometimes as early as August. I have been a long time proponent of people waiting until October or November to get the flu shot, because the duration of immunity, particularly in older people, is really only 3 months. So, and we usually get our peak in Rhode Island. Our peak flu vaccine activity is February and March. So if you get vaccinated later in the vaccination season, you do better. But this year, I've been beating the influenza vaccination drum for many years. This year is the year to do it if you've never done it before. And if you've done it before, do it again this year. But again, I'd say wait till October or November.
Can you get 2 flu shots?
Well, technically you can. Often your insurance company will only pay for 1. So that's a personal decision. There's also a higher potency flu shot now available for people over 65. That probably will help some as well.
Let's go to what's going on in Pawtucket and Central Falls. Is there any news out of that? I know Mayor Diosa has been really trying to get the message out. And unlike other elected officials, while he's getting the message out, he has got his mask on.
Well, he's been a real champion, not only of masking, but of taking this pandemic and attacking it frontally. But there's an extra reason for doing that. And that extra reason is that the city of Central Falls has the highest per capita incidence of coronavirus in the state, 6 times higher than Barrington, twice the state's average, higher than Providence. The test positivity rate in the one site that's testing about 10 people a day in Central Falls, that's it. But that one site is running a 32 to 36% test positivity rate. So we've got a big set of challenges. The good news is this is a whole community involvement. We're trying to get everyone in the community, and Mayor Diosa is leading this, trying to get everyone in the community involved in fighting back. There's a campaign called CFP Beat COVID-19 that is a widespread campaign, and there are going to be lots of announcements over the next week or two about the things that we're doing together to reach out to every single person in the community. We're talking about temperature screening and some other things, just trying to make it so that we touch every single household and get every single person into some kind of meaningful isolation the moment they get their first symptom.
Dr. Fine, what do you see the state's next week to 10 days? Where do you see the numbers going? Yesterday was the highest number of confirmed cases, as you said, nearly 400. That obviously starts to look and feel like we're entering the surge.
Well, again, one day is a single day, and I don't want to make predictions based on that one day. My guess is we will see the gradual upswing of hospitalized cases, the gradual upswing of number of cases, and continue to do that for some time. I don't think the next week will look terribly different than this week. We'll probably see a 10 or 20% increase in number of cases and number of hospitalizations. I hope it's just that. And we'll probably see 10 or 20% a week for the next 2 or 3 weeks, and maybe a little more, and then a fairly long leveling off. But again, we play it day by day, and a single day doesn't predict anything about the future.
I don't know if you saw the report, but California has announced that they've tracked 2 cases, 2 deaths to roughly mid-January. Those are much earlier than what had been thought to be the first death in the United States, which was in Washington, I believe in early February or late January. This has made lots of people rethink the whole time frame. And also, there's no linkage to a trip to China or anything like that, that both those individuals were infected by community spread. Is it that despite our guess, despite all the proclamations, we just don't have enough information about this disease yet?
Oh, I think that's really true. I mean, I heard something about a congregate setting yesterday that was incredibly interesting. The timeline of a single case in a congregate setting really suggests it was someone who went 16 days asymptomatic, well isolated, before showing disease. And if that's true, and there's no reason to think it's not, but if that's true, our use of 14 days as the time of isolation may turn out to be something we need to change. And we need to start thinking about 21 or even 28 days of isolation till we get meaningful disease clearance. I think we've got lots to learn about how immunity works in this disease. There are some things that we know about coronaviruses generally, and the difference between infection and between what's called asymptomatic carriage. So that when you get a deep-seated infection, when you get a fever and a bad cough, and even pneumonia, I think you're more likely to develop meaningful and lasting immunity. And obviously, when you're infected like that, you can spread disease. But if you get a little virus sort of, replicating a little bit in your nose and nasopharynx and not really causing infection, you can, on the one hand, spread disease, but you are, it seems to me, possibly not going to get the kind of immunity that will protect you long term. And it wouldn't shock me if we don't discover that there are these 2 categories of involvement, and that we're going to have to start thinking about them differently if we're going to get control of this disease. The other story is a story that came out of China, and I don't know if you saw it in the press, but it was the story of a family who left Wuhan right before they closed Wuhan. And they got out of Dodge just in time, so they thought. They went to a city 500 miles away, and they went out to dinner. There's great public health work that was done in China tracking what happened when they were at dinner. They actually were able to figure out who were at the tables around them and what happened when one member of that family developed symptoms. And when that happened, obviously they breathed or coughed or sneezed or something. And the air conditioning system of that restaurant moved the air in a very specific way so that people at tables downwind, as it were, specific tables, 5 people got infected, but nobody else in the restaurant got infected.
Amazing.
That's the kind of thing that we're going to learn over time, as we understand first that this is a disease that is aerosolized, that doesn't just spread on respiratory droplets. And we're going to understand how it spreads and where it spreads. But we're just at the beginning, and we're still pretty much flying blind.
Yeah, I think one of the more concerning little tidbits of information is Germany, who has done a very good job controlling spread and has a very aggressive public health system in tracking and unveiling some interesting information. Germany has already canceled Oktoberfest. So that's an indication that at least that country thinks that controls and limitations are going to be with us for a significant period of time. Dr. Fine, the last word, your thoughts?
Well, I think we're going to rediscover local public health. I think we're going to have to figure out how to do this town by town and city by city. Tomorrow, I hope to talk about the difference between Block Island and diseases and places with more disease, and what we learn in terms of who can open when and how to open them. For the moment, stay safe, stay home, and at the first symptom, please get into meaningful isolation.
Dr. Michael Fine, thank you as always, very, very helpful. I want to thank the earlier guests, John Wolf from San Miguel School and David Sirota, former speechwriter for Bernie Sanders, top consultant to the Vermont senator in his presidential bid. He has launched a new newsletter called TMI, Too Much Information. You can sign up for it on his website, davidsirota.com. The governor's press conference will be at 2:30. I apologize for flagging it at 1 o'clock. Monday, Tuesdays, Thursday, Friday are at 1 o'clock. I've forgotten that it's Wednesday. It's at 2:30 today. Thanks everybody for tuning in, and thank you, Dr. Fine. Please, everyone, stay safe.
Thanks, Josh.